Hi, thank you for joining us as we continue on our mission to change the conversation around primary care. As we seek to rebuild our healthcare system, we believe that it should be one foundational in primary care. So we're excited to continue the discussion today. I'm Stephanie Quinn. I'm the Senior Vice President of Advocacy, Practice Advancement, and Policy here at the American Academy of Family Physicians. We represent 133,500 family physicians and medical students across the country. And we are pleased today to continue our conversation around primary care innovations in Medicaid. Before I introduce our speaker, I wanted to give you a brief introduction and overview of what the Primary Care for America collaboration is all about. We're a diverse collection of key partners that is focused on educating policymakers and health policy influencers about the real value of comprehensive, continuous, and coordinated primary care. We look forward to ensuring that legislative and regulatory action is really pursued in service of improving our healthcare system. Dr. Odom Walker, throughout her career in academia, has worked on primary care outcomes research funding in the state government and also in health systems. Prior to joining Nemours, following public service in the state of Delaware, she served as the Secretary of Delaware Department of Health and Services. We are pleased to have her with us today.
Thanks, Stephanie. Thanks so much for having this conversation as a family physician and one who's been continually at this intersection of health policy, population health, and the foundation is based in Medicaid. And so it's great to have this dialogue with the audience today. Next slide. Just by way of background, my role within Nemours Children's Health is a unique one. We are a pediatric health system focused on serving those in multiple states and multiple sites. And because of that, we have this interesting view of state policy and politics, but also have a role in creating a voice and dialogue nationally around children's health issues. Children don't live in a silo, they live in families. And for that reason, it really is important to think about the foundation of primary care. Nemours Children's Health is an outreach of the legacy of Alfred I. DuPont, who said that all children should have access to health care. But it has also allowed us to expand our mission around being an academic system that's fully committed to clinical care, research, and education. Up to about 60% of our patients are Medicaid eligible children. And for that reason, we often think about how we connect the dots between Medicaid and the social determinants of health. Next slide. I think it's also really important to understand a bit of the context and opportunity that Medicaid presents. We know that Medicaid federally accounts for about 1/6 of the total healthcare spending in the US. The number's growing with COVID and the number of families who have become newly eligible. We know about 3/4 of Medicaid spending on services is for acute care, but the actual largest growing segment is in nursing home, long-term care services, and supports. And we continue to see enrollment increase. So these are a bit outdated, but I think it's important for context to just see the number of enrollees is majority children. The expenditures are much lower in this mostly healthy population. And we continue to see increased areas of growth among the elderly and disabled. I think this also gives a strong incentive for states to think about how to manage Medicaid costs. It's often the largest driver in state budgets, and it's the largest intersection with the federal government. Next slide. For this reason, I think Medicaid presents some very unique opportunities from a policy perspective around thinking about collaboration. And that collaboration is circular. It is foundational in the federal government based on statute, but state policy and resource allocation often is the key to success that need alignment, collaboration, and coordination. And there are so many flexibilities built into state Medicaid waivers. Every state Medicaid program is different. My experience in Delaware is unique in that I know Delaware Medicaid inside and out. But every time I would talk to colleagues, they would say, these are the other opportunities that exist across our nation. We also know that federal incentives can incentivize states to do really creative things around value, around population health, around primary care. And they can use regulatory levers, flexibility, but leadership is essential. And the opportunity to create greater flexibility, to expand what we know matters right now around rebuilding back better after COVID, around creating more incentives to think about community health and testing and how we think about the intersection of health and where we live, work, and play is really essential. The local environment also gives unique opportunities to push the needle in terms of supporting primary care. And I'll share a bit of my reflections and the opportunities ahead of us. Next slide. We also have a significant opportunity, and for those of you who want to get your very own copy, I've put a little header out there, but there are ways to leverage this report. It was a consensus study done by the National Academy of Medicine to think about how we implement and support high quality primary care. We know that right now, most of primary care is still fee for service. We're trying to get further to the right in this model where we get to global budget and capitation, not the HMO version, old school, what we thought about capitation, but truly total cost of care that incorporates nursing home, hospitalization, emergency department utilization. And we need to think about how to use those policy levers to support transformation. We also are getting into a space where we know that teams matter, that it's no longer just Kara Walker as the family doc taking care of my patient in front of me, but it's how me and my team coordinate, the community health worker, the promotora, the person who's looking at the data to see who is high risk for not necessarily receiving the routine and preventive care on time. I need those team members, and I need to have a payment model that allows me to incorporate them into the normal workflow. Places that are doing this well and have a lot of experience are finding out that that is where we can really expand this notion of primary care, that a primary care medical home is beyond the doctor, but it really requires thinking in a new way. In Medicaid, most states have broad flexibility to determine how they think about paying for physician services. But where there are opportunities, I think, in the federal landscape are to think about primary care as a value to health and to think about how we change the reimbursement paradigm. We can get there through a few key opportunities, and I'll talk about those as well. Next slide. We also know that in terms of getting to this value-based payment continuum, the biggest challenge is the upfront investment from getting to fee-for-service to capitation or a total cost of care model. In order to get there, it often requires investment. Now, health systems like mine and Moore's, we can figure out how to bring back some of the dollars and invest in our primary care because we have a bit more flexibility. But in the individual or small practices, we often need incentives built into Medicaid and built into other payment structures to allow for that investment to get to a prospective payment model where they can then take the chance to pull on risks, shared risks, upside, downside risk, and to pull into these capitated models. It also requires thinking about how to resource the community connections and our connections that are essential with social service organizations. If I have Mrs. Jones in front of me who has food insecurity and diabetes, I know that getting her healthier food matters, but if she's food insecure, I need to make sure I'm connecting her with local resources. And sometimes that takes time. It takes time that is way beyond the typical medical encounter. And so we need to figure out how to build in those incentives and investments along the way. We also have a very unique challenge around prevention that often the fee-for-service model does not allow us to invest upfront in prevention and upstream issues. We call this the wrong pocket issue or the long pocket issue, that those who are paying for services today often aren't seeing the return or the direct compensation and return on investment downstream. It definitely affects kids. It affects multi-generation family needs. And we need a bit more flexibility, and policymakers have a unique opportunity to think about that longer term return on investment horizon through building in waivers, pilots, or innovative models that incorporate social determinants and other social services into new strategies and new ways to pay for primary care and supportive care. This idea of paying and taking care of the whole person is essential. It's core, foundational to primary care, but it is not the way that we pay for care. I can't figure out how to get a child who has asthma, who misses lots of days of school, the resources needed to make sure that they stay in school and their asthma is controlled, because often that means putting resources into the educational environment, and those dollars are separated out and distinct. It also means having an educator or someone go into the home and remove old carpets and really think about how to provide that holistic care in a different way. This is part of our challenge in this continuum, and I think we have a unique opportunity to think about moving down the spectrum and investing differently. Next slide. So I think this is the challenge. We know that primary care is a very small portion of the overall federal budget in healthcare. It is largely in fee-for-service. Technology, devices, and other areas of innovation are far outpacing spending increases in primary care. And so we have to decide what is the right investment, what is the appropriate line in the sand in order to make sure that we have primary care, chronic disease management, population health strategies built into how we think about healthcare today. There is a return on investment, but it may be a little bit further out than a 1-year contract or a 3-year time horizon. And so we have to really figure out how to build that into Medicaid policy. We also know that Medicaid pays less for primary care services than it does for specialty care, than it does for other domains of healthcare spending. There are ways to incentivize states to think about investing. Some of that is through managed care contractors. All states have them. There are ways to encourage them to build in equity measures, for example, to pay bonuses for improved primary care, for high quality primary care. Again, there are ways to increase and adopt high quality primary care through data analytics that can be embedded into managed care contracts. All of this could be incentivized through federal levers and regulatory measures. We also know that the commercial space is challenging from a policy standpoint, and definitely in contrast to what we can do within Medicaid. The dynamic is really unique in that commercial payers pay specialists more than primary care physicians, but they also have more opportunity to think about the investment and value. There are ways to think about aligning Medicaid, because if Medicaid creates that innovation, often the commercial payers follow, and I think that's an important point to note. Next slide. So I think I would highlight these 3 opportunities, and I would say that if you're wondering where to get started, these are 3 key areas that I think are high potential. One is around measuring and standardizing primary care spend. States are figuring out how to do this. I'll highlight again a quick example from Delaware and other states who are doing this work. This is an idea that could be implemented nationally, where you measure and understand primary care spend with a standard definition and provide that back to states so that they can base initial targets and investment strategies on what current primary care spend is in. It could be done across payers. It could be done just for Medicaid. It could be done for Medicare. I think this would be a great opportunity to understand what we're doing in upstream investing. The other ways to increase support to primary care innovation are to think about it as an investment, to make sure that we're thinking about the dynamic between how payments are set between primary care and between specialty care, how we think about investing in the data analytics and health information technology to make sure that I know who all of my diabetic patients are from one glance. But building that out practice by practice is very challenging without some upfront investment. The other way to do it is through thinking about value and risk arrangements. And there are several federal initiatives moving forward around thinking about how to create pilots for value-based payment that are foundational and create a starting point for primary care practices engage in getting paid for health rather than paid for services. These often involve risk arrangements, and you'll hear that often. The devil are in the details, but I think there are ways to make sure that there are federal flexibilities to make sure that we can incentivize measurement and the right pace to keep track of how we're investing in all of the elements of high quality primary care. Next slide. So there are many examples with significant return on investment in investing in primary care. And this collaboration requires a federal leadership approach that looks at the CMS authority and regulation. It also requires thinking about covering prevention, access, measuring social determinants of health, which we don't do a great job of yet because we haven't necessarily come up in the billing world, thinking about how to code for understanding social factors like food insecurity and transportation risks. We also know that states have leveraged their 1115 waiver authority. Just look at North Carolina or Oregon and the way that they've used that 1115 waiver authority. CMMI has certainly thought about how to create new models and on-ramps that that create some technical assistance and opportunities for states to think about their 1115 waiver authority. But there are other ways to do it. One example is collective impact funding, social impact bonds, other ways to think about this wrong pocket issue around how do you really invest earlier on to create a healthier generation down the road. I would also like to highlight the local initiatives, and in some ways the federal policy opportunities exist because of the local input in how we think about school-based health and wellness, how we use the dollars that are built into the American Rescue Plan Act to really think about investing in these intersection school reopening could be really repurposed in some ways to think about the intersections with primary care and prevention. But there are also longstanding programs that exist that could be elevated, like the Nurse Family Partnership, where we know the investments early on and those who are eligible can produce a range of outcomes around education and recidivism and family supports and mental health that could be another opportunity to think about this intersection and collaboration between federal, state, and local initiatives. Next slide. I just thought I'd highlight this one example. This is the work that we did in Delaware when I was Cabinet Secretary for Health and Social Services around measuring healthcare spending. Embedded in understanding rising healthcare costs in the state of Delaware, we also decided collectively with Governor Carney's leadership to establish an embedded measure around primary care spending. You can read about it online. I gave it a snapshot of this website, but I think it was a really important conversation around how do we support better health? And what came up time and time again is the need to understand and support primary care. We needed to make sure that we had a collaboration across stakeholders to bring people together with expertise in providing care, in payer landscape, in enrollment, and in community-based services. So this is just one example of how states are taking this challenge on and could be adapted to federal policy opportunities. Next slide. The second opportunity is engaging primary care physicians themselves as a voice. Their stories are meaningful. They resonate with legislators. I think that what we saw is that this dialogue around healthcare and healthcare costs, and even in the COVID context, I think primary care is even more appreciated. Thinking about how to establish a dialogue is part of what we need to do, and coordinated federal leadership, I would say, is a key opportunity. Again, as one state's example, but we established a primary care collaborative to bring together the voices of primary care to figure out how to engage stakeholders in the public, how to engage the public sector, how to engage private payers and employers in this conversation. And what came of it were several bills that allowed us to think about this collective conversation and stakeholder input around creating a fund for primary care investment to really think about how that's tied to hospital and other non-professional services and their costs, and then to try to adapt affordability standards that in some ways are a proxy to primary care spend, to measure and define it and to understand better where we can go and how we set a goal in the future. Other states have done this a bit longer than Delaware, but I think it is a model that could be high impact. Next slide. So this type of state policy does make a difference, and we've seen the impact in states listed here. I think there are even more states to add that are on this journey, but thinking about how you create the interconnection between the vision of primary care and transformation towards better health and improved costs. We know that the foundation is in primary care, the way to keep people healthy, but we also know that that investment in the care model and the team is critical to getting there. And that requires, a little bit of chicken before the egg conversation. Which one do you do first? I think asking primary care physicians to do that without some help and some investment is very challenging. We also know that politically speaking, primary care and increased primary care spending is consistent with evidence for health. And it also is something that engenders political goodwill. Most of our legislators were very familiar and would tell the stories about working with their family physician, their internist, their primary care doc, and would say, I think they definitely need more support, and they're working so hard, especially with COVID challenges and changes, to try to make sure they're keeping up and keeping their doors open. We also know post-COVID, we need primary care more than ever. We need them to survive and thrive. We need them to be available to make sure that they're providing services, whether it's through telehealth or direct care. But we certainly have a ways to go to manage out of this pandemic. Next slide. So there are payment reform options, and I think this is a place where, again, the collaboration is key because the federal policymaking can set the threshold and then states can choose to adapt those incentives. There are many ways to encourage states to take on this opportunity, whether it's building in incremental change into the rate setting process for Medicaid. That can be done again through increased incentives, to build in things like equity measures into managed care contracts, to think about payments specific to high quality primary care, and encouraging that adoption at the state level would go a long way. You can also think about pilots to build out fixed payment models. And I would say this is an area of a lot of conversation around how to do this for the whole person, not just their health needs, but also what happens at the intersection of health literacy and neighborhood and environment, and thinking about the patient-centered medical home, where we know that quality and patient experiences can be improved, but global payments give the flexibility to get outside of the walls and make sure that practices are ready for this risk. There are also models that exist that have been accelerated by CMMI, such as the Comprehensive Primary Care Plus model, ACO model opportunities. I could go on and on. There are amazing work being done and being thought through in terms of how do you best incentivize it. I would say there's not going to be a one size fits all. And so we need to really figure out how to get these payment models beyond the walls of medical practices and incorporate social services where we know there's the greatest opportunity to create improved intersections. We also could really figure out this idea around where do we want to be in the future? And again, if COVID has taught us anything, it's that primary care matters, and that health matters. It matters for all of us. It matters for our economy. It matters for our ability to thrive and survive in this global environment. So maybe we do need a larger goal around how much healthcare spending goes into primary care. And primary care oriented payment models may be one way to get to better population health as well as lower spending. But the way to get there, I think, is through a standardized approach to measuring primary care spend and these investments in non-fee-for-service arrangements, pay for the X-ray and the visit, but really thinking about how do I keep all of my patients as healthy as possible. Next slide. So I'm just going to wrap up before we go to a conversation. In all, this is another National Academy of Medicine report around incorporating social care into the delivery of healthcare. And it's just, to me, a reminder of how complex it is, but how many opportunities we have to think about the policy levers, whether it's around investing in standardized data and measurement, whether it's encouraging comprehensive needs assessments and social screening tools to be implemented and tracked, or whether we think about how to increase the tools that are available to navigate very complex social care networks. Do we create these collaborative partnerships and also create some funding to make sure that entities and social network platforms can be used to connect the dots in the right way? Is it something we should be able to do on our phone every day, or something that the doctor should be able to refer to a supporting social service agency and then track and close the loop? We're still trying to figure this out, but many are trying things out. We need to encourage and incentivize that. I think around care continuity, this is another place where there are significant opportunities to encourage this longer term horizon around return on investment measurement, but also how we're thinking about all the changes that happen. If I ask one of my patients about food insecurity today, they may say, I'm fine, but then 2 weeks from now, when I'm not with them, they may have a different circumstance, and we need to be able to adjust. I think that thinking about engaging patients is even more important than ever, making sure that we're individualizing the experience. We're thinking about the health of individuals, and some of those patient engagement strategies, those patient-centered measures could be incorporated into federal innovation waivers, and trying to really think about how you encourage the collection of this information, how you encourage making sure that community representation is at the table when we're trying to think about new strategies and leadership. Additionally, this day and age, I can't not mention the importance of health equity and how we measure that. And again, some states are incorporating equity measures and bonus payments into their MCO contracts. Is that another area where federal levers could be encouraged, incentivized in some standardized way that could encourage our collective impact around health inequities that exist in our nation? Next slide. So I just want to say thank you so much. Nemours continues to elevate the need around increasing access to health and healthcare for children and youth. We're also very committed to raising the needs more broadly around creating the healthiest generation of children, whether it's integrating mental health needs with physical health needs or thinking about leadership structure that is necessary at the federal level. I think there are many opportunities to continue this dialogue, continue to support families, and continue to support primary care. Thank you so much.
Thank you so much, Dr. Walker. And I apologize again for your botched intro. You've had such an impressive career. And it's worth mentioning that prior to becoming secretary of the Department of Health and Social Services, you served as the Deputy Chief Science Officer at the Patient-Centered Outcomes Research Institute. I think your career in academia and research, state government, and health systems really gives you a 360 view of the Medicaid program and where there are challenges and opportunities. So I just want to thank you again for joining us.
Sure.
So let's hop right into questions. The first question is, how can value-based programs serve pediatric primary care practices and networks?
So I think that there are so many opportunities to think about how we envision the future of pediatric care. Again, I think back to that first slide I shared, Stephanie, where we were really thinking about what is the dynamic. We spend a lot of money in long-term care, nursing home care. How much could be prevented if we invested earlier on in the lives of babies, infants, and youth? But I would say we need a lot more research and testing of these models. Most of the innovation models are in the Medicare space. There are a lot more federal flexibilities. Medicare Advantage is setting an amazing model for what could be done. I think that the challenge with pediatrics is we need kind of a longer term horizon to measure the impact, whereas for elderly population, you can do this in a shorter time frame, 1 or 2 years, and see the impact of your strategies. We have built out a clinically integrated network at Nemours, which allows us to see this promise in building out infrastructure and things about care teams and the role of community health workers. I still think there's more to do at the intersection of education and health that is exciting to think about. It's also really hard to do because the pots of money exist in different places, and we don't necessarily have coordinated federal leadership to pull together all the different places where we can impact health of children. So upstream issues are hard. We call them long pocket and wrong pocket issues. I think federal policymaking exists to make it easier. And there are great conversations happening in Congress with the establishment of a new social determinants of health caucus, which we're really excited about. I think that's a place where some of these conversations could happen and really think about how you invest earlier on in our children's trajectory.
I agree. What are some of the ways that states can support team-based primary care within Medicaid programs?
There's so much going on, and adapting what is happening in certain states, I think, is very encouraging and inspiring. So talking to states about how to think about mental health supports and investments right now is key. Often they are carve-outs, and I think we know more than ever the interconnection between mental health and physical health. And again, I think to emerge from this pandemic, we need to really think about how the substance use and other mental health needs are expanding, unfortunately, and not declining. We also have to figure out how to promote the right workforce. So investing in training, investing in those who have the capacity to think about quality improvement and training and equity measurement is another place where we can figure out team-based care approaches. Again, I would highlight some of the work out of North Carolina around creating these social determinants of health platforms that allow a provider to say, I want to connect my patient to resources in their community, in their neighborhood that are culturally tailored and appropriate, or how the work out of Oregon has really said, we're going to pay holistically for care in a certain region and community can give us flexibility. So I think those are just a few examples within the Medicaid program that could be lifted up and accelerated.
Great. Thank you. One last question, if you have time.
Sure.
How can policymakers help with the development of more equity-focused primary care value-based payment models for Medicaid beneficiaries?
So we could talk for an hour about where I think there are opportunities here. I know that's not what you're asking me to do. So thanks, Stephanie, for a great question. I'll highlight 4 areas that I think are high impact. The first is around encouraging data collection and standardization for social determinants of health and cross-sector integrated data. So quick story, as Secretary of Health, the thing I most wanted to be able to do was to look at which families were receiving services in multiple agencies in the state, and then understand what other gaps I could fill that maybe these same families didn't know about. And we just don't have easy ability to create those integrated data connection points and understand where there are gaps and where there are opportunities. So I think that would be incredibly helpful from an equity lens to have this data available. The second is around creating incentives and technical assistance to help providers look at their equity gaps. So we're building this out as a system, but every system is trying to understand equity. So, is there an opportunity to really provide technical assistance to allow those who are motivated to look at their equity measures to do it in a high quality way that's meaningful and impactful? I think that would be an important way to think about the policy levers there. The third is around encouraging incentives for equity and for reduction of inequities. Pennsylvania is doing this. They're embedding quality incentives into their managed care contract to close gaps in care. This could be something we do for flu vaccination, for other primary care measures that every provider wants to figure out how to solve, whether it's diabetes care, congestive heart failure, quality measures, but build in that ability to look at it by race, ethnicity, by language, I think would be another area that policymakers could help. And the fourth, I'll just throw in there as a bonus, is that thinking about collective leadership really matters. So some states have children's cabinets. I think they have shown an example. Other countries have children's cabinets. Wouldn't it be amazing to think about coordinated federal leadership around primary care, around children, around youth, around families, to create this leadership around integrated and braided funding that could support holistic health and whole person health in a new way? And I think that's my short list, my short answer for today. I could go on.
Even some ways to communicate shared learning, so that, if things are coming that should be elevated as best practices or lessons learned or things to avoid, that those are being shared.
Absolutely.
Well, thank you so much for your time today, and really thank you for joining us on this mission. And we look forward to working more with you in the future.
Same, Stephanie. Thanks. And thanks to everyone who's listening.
I'd like to take a few moments just to walk through, I talked a little bit about what Primary Care for America is, but I want to walk through a little bit of the why. We are speaking up because as it stands, there is no shortage of evidence that over the past decades, the benefit of primary care investment, the impact that it can have on individuals' health. Despite the fact that we spend twice as much on healthcare, our outcomes for most conditions are worse than many other countries such as Australia, Canada, France, the United Kingdom. And I think the COVID-19 pandemic has really illustrated this and underscored the limitations of our current system and the impact on patient access and health quality. And so, primary care physicians have really been on the front lines seeing the limitations of this system and the impact that it has on patients. And it's time we change that. Next slide. And really, we are looking at our current system and in building in the National Academies of Sciences, Engineering, and Medicine's report released in May of this year. Primary Care for America has outlined some principles and areas of focus. We really need to move our system from one that currently incentivizes sick care. And we need to improve access to comprehensive and continuous primary care, especially for those in underserved communities. And that will entail removing barriers to accessing care, such as workforce shortages and health insurance status. And some of that is going to be needing to grow the primary care workforce. We can't address people's healthcare needs if there's not a workforce to meet them there. And making sure that the infrastructure is flexible enough to allow for innovation and the ability to tailor to individual community needs. And making sure that there's an increased focus on the comprehensiveness of care. Next slide. I would say that the Primary Care for America, our North Star is really to invest in a healthcare system that prioritizes health and values an integrated approach. And the collaborative has taken some near-term and some longer-term goals to accomplish this. And first, we need to really demonstrate the value of primary care and increase that awareness and understanding. And we need to increase the investment, and that will help drive innovation in primary care and payment design. We need to position primary care as a solution to many health policy challenges. And hopefully the outgrowth of that is that we are growing the primary care workforce, and that we're prioritizing primary care and benefit designs, and that there is a competitive marketplace for primary care practitioners across the country. Next slide. We recently sent a letter to Secretary Becerra outlining areas of focus for this coalition. And the two main areas are innovation in primary care delivery and payment, and workforce transformation and expansion. And these are areas where we believe the administration is uniquely positioned to drive a lot of this change. And we're really excited about partnering with them. If you want to see the letter, you can visit the link below. Next slide. We would encourage you to continue the conversation tomorrow, 12:30 p.m. Eastern. We will be on Twitter, and many of our partners will be engaging in the conversation as well. And that will be at PC for America, and we hope that you will join us. Next slide. And don't miss the last in our series. There will be September 30th, where we will be digging into the commercial insurance and employer markets on primary care innovations in that space. Lastly, I would really just like to thank our founding partners. They are jointly committed to this mission to drive forward primary care, and we look forward to sharing our work with you ahead. Thanks for joining us, and have a good day.